So starting with spina bifida and other neural tube deficits. So just to remind you, the neural tube is that tissue that actually develops into the CNS. It happens early. It's the brain and the spinal cord. It happens early. It happens by 4 weeks of gestation. So the issue with that is that sometimes it doesn't close all the way. And when it doesn't, it leaves really pretty significant problems for the child. We don't know why this happens, but we do know that one of the big risk factors is the fact that when people don't have enough folic acid, or if they don't metabolize it in a way that's good for the baby, if they metabolize it too fast. So basically it was 1992 is when it said all women of childbearing age should take folic acid. And that is hard to do. So what they ended up doing was by 1998, it was mandated that all enriched grain products like bread, cereal, and rice to be fortified with folic acid because of how important it is, and because, this closes in 4 weeks. Women usually don't even know they're pregnant at 4 weeks. Like about 4 weeks is when you find out you're pregnant, so you likely haven't been taking folic acid. So with it being in the enriched grain products, I was looking this up on the CDC website. It said that 19 states ended up tracking it afterward, and that there was a 28% reduction in neural tube deficits after this went into effect. The other neural tube deficits that we're going to talk about a little bit are anencephaly, spina bifida occulta, and then spina bifida cysta, which is meningocele and myelomeningocele. So anencephaly is the most severe. And you can see in this picture why it's so severe. The whole top of its head's gone, right? So what happens in this is that the top of the neural tube doesn't close all the way. So there's no development of the brain, or very little development of the brain above the brain stem. So it's the most serious one. It's incompatible with life. Some of them, so these kids have part of their brain stem typically. So some of them, and remember your brain stem helps you maintain some of the vital functions, like temperature regulation, cardiac, and respiratory function. So you can live potentially for a few hours or even several weeks, but you will die eventually from respiratory failure, or these children will die of respiratory failure. Many are stillborn. A lot of them don't even have enough of the brainstem to live very long at all. You provide comfort measures, but you don't. With these kids, we don't resuscitate. And obviously, the family needs emotional support and counseling. With ultrasound now, I would think that there aren't a lot of surprises, that people would kind of know this is happening, although, as we know, and I'm sure since you're doing OB now, a lot of people just don't get prenatal care. So there could be some that are really not anticipated for that reason. So spina bifida occulta. So spina bifida is Latin for split spine. And basically what happens is there's a vertebral defect. So the posterior part where the vertebral arches are, that doesn't fuse in utero as it's supposed to. So this typically happens at the L or S spine, the lower spine. But in occulta, the spinal cord and the meninges stay in the vertebral column. So you'll see as we go on to these other ones, this one is much less severe because of the spinal cord staying where it's supposed to. It's the mildest type. It's sometimes called the hidden spina bifida. There's a small gap in the spine and no sac sticking out of the back. And the sac sticking out of the back, we're going to talk about soon. The spinal cord and the nerves are usually normal, and it usually doesn't cause any disability. The disturbances, sometimes there are disturbances that can arise during periods of rapid growth, and sometimes that's when it's noticed. So they might not notice there's anything at all until the child walks or is potty trained and has some difficulty. But a lot of times they really just don't have any problems at all.
Can you get it later in life or something?
You don't get it later, but you can notice it later.
Yeah,
That's what you mean?
I feel like the girl that
Oh, really?
Center of the spine.
Did they just think it was a birthmark or something? Like, it must have been pretty small, I would
Yeah,
guess.
and then it like got bigger. So then she couldn't play sports anymore, I guess.
But yeah, it's not something that develops later. Like, it's something that just didn't develop during utero. So if it wasn't noticed, then that was clearly an issue. But so the superficial indicators are a lot of times you'll have a dimple or depressed area, dark tufts of hair, soft cutaneous lipomas, which are just little fatty deposits, or port wine nevus, which is that's the dark, deep red purple macular lesion. These are all in the lower back. It's definitely something that you should look at. One of my good friends had a child who didn't have any of these symptoms or these little indicators, but the pediatrician noticed that the child, on her buttocks, the crack was just a little bit off. And so they sent her for evaluation, and she didn't have spina bifida, but she did have a tethered cord. So that area is just something to look at, pay attention to. If you do notice something, then an ultrasound is what is done to look at to see if there's anything, if there is an issue below there at the spinal cord. Oh, sorry. Let's see. Contained. Contained is the blank. Spinal cord and meninges are contained in the vertebral canal. So spina bifida cystica is when there's actually a pouch coming out of that area. So in a meningocele is the less severe of the two. That's when there's CSF and a stack of meninges, but no cord comes through that opening. There's little or no nerve damage, and it typically just causes some minor disabilities. But with myelomeningocele, so it's the CSF and the stack of meninges, like the other, but then it also has some spinal cord, and it's damaged from being compressed in that area. So it's the most serious type, and it causes moderate to severe disability, ranging from incontinence to paralysis. So here is a picture to kind of show you. So you can see with occulta, so that deficit is there, but nothing's happening. Like as far as like nothing's pouching out, it has that little tuft of hair in this picture at least. And the meningocele, it pouches out, so it has a deficit like this one, but it's more severe. It pouches out. And this, it is the same, except that the spinal cord's coming out too. And you can see that that's putting pressure on that. Plus any sort of external pressure. I would imagine that, I don't know for sure, but I would imagine if you know this is happening, that they would take these kids via C-section. So there's no traumatic birth before they fix them. Somewhere, let's see. When they know this is happening, sometimes they'll go in at about 26 weeks in utero to fix it, to do surgery to fix it if possible. And but that the risk of that is preterm labor and delivery. The children that are born with, that they decide for whatever reason not to do surgery, or they didn't have prenatal care or whatever, those kids have surgery usually within 24 to 48 hours because the risk of infection is so severe. So here is a picture of what it looks like from the outside, and then what it looks like when it's fixed in this particular patient. But there are some not so extreme pictures on page 1632, if you want to see some that are not quite as bad as this. I'm sorry, 1632? I'm sorry? So it's definitely not as bad as this particular one. As anything, there's a wide range of what these things look like. And it depends on where it is in the spine, as to what kind of deficits they have. So nursing care, assessment, always critical. The deficit is readily apparent in this particular one. And then you should also observe for associated anomalies. So in these kids, typically about 80 to 85% of kids with spina bifida have hydrocephalus too. And it's due to either blockage from the CSF, of the CSF, because of a deformity. And one of the deformities that's common in spina bifida is this Chiari-2 malformation. And basically what that is a malformation that causes downward herniation of the brain into the brain stem. And a lot of times it doesn't cause any problems at all, but the risk is that it can cause sudden death because it's herniating through the bone in the spine. So when that's discovered, usually a cervical laminectomy is done to take that pressure away. So that is one of the things that you look for when kids have spina bifida, is do they have this anomaly with it. Another thing that kids can have is clubfoot, which is something to look for that's not as serious. I think should talk about it later. Hold on. Chiari, it's Chiari. 2 malformation. They talk about it a decent amount in the book. So as far as being the nurse for a child with spina bifida, what other things would you look for and assess in your patient? Yes, neurochecks for sure, and then to check the sensation in their legs. See if they move their legs. Look for a CSF. You can look for cerebrospinal fluid leaking. Some of these are intact and there's skin over them, and some don't have as much skin, and so the CSF can leak. We would watch for bowel and bladder function, because if it's severe, a lot of times they won't have, and depending on where it is in the spine, if it's pretty low in the spine, they likely wouldn't have bowel or bladder function that they can control. And then their respiratory patterns. So this Chiari-2 malformation, while it's often symptomatic, if it is symptomatic, often is respiratory issues. They might have apnea, stridor, a hoarse cry, or feeding problems. So how do you think we'd position a baby like this while we're waiting to have surgery? Yes. We clearly don't want to lay it on its back, right? So when you put it prone, it also is recommended to put the hips slightly flexed and abduct the legs to minimize tension on that sac. And also to keep the baby under a warmer. And then with the sac, it's under the warmer. We don't want to dry it out, right? So we want to keep some sort of sterile moist dressing, moist with saline, over the top of it. And then what about a diaper? So we don't really want anything to touch so we're going to put some sort of saline or something over it to keep it protected and from drying out. But as far as diapers, we need to keep the diaper off of it. So I think I would imagine what happens for this is that you put the diaper under the baby to kind of catch, and then I would think that you put something lower, like on the lower back, like under the malformation, to kind of keep from, like if the child does stool, from coming up, because we don't want stool in there. I think that at that young, the stool is fairly sterile compared to other people and older children, but still we wouldn't want anything on it. Another thing to think about is just not doing any rectal temps. In kids, we do a lot of rectal temperatures, but not in these kids in case there's any sort of sphincter involvement. Like we don't know at this point exactly what's involved in a new baby. So that'd be something to avoid. So the highest priority nursing diagnosis, what would you think that would be in a baby before they've had surgery? Risk for infection, definitely. And also another one to consider would be preventing trauma to that cord. Other things to think about are just parental bonding. Like you want to involve the parents in the care. You want to educate and encourage them, but they can't hold them at this point. But there's other things you can do, right? You can stroke them, caress them, talk to them, kind of, be in their face so they can be familiar with the parent's face, or at least see their face, which I think would make the parents happier under the circumstances too. So surgery. Like I mentioned a little earlier, it can be done at about 26 weeks, but then 24 to 48 hours because of risk of meningitis. The post-op care is really just your routine surgical care, but to keep the baby prone or side-lying, not to lay in the surgical area. A couple of important points are that these surgical procedures do not cure it. The damage has already been done to the spinal cord. Like you can't fix that, at least not in this point in time. But it will, bring down your risk for infection. It will fix the physical deformity from the outside. And these kids will likely have bowel or bladder issues as a long-term issue. And then some, as I briefly mentioned before, some will be, depending on where it is, the higher the deformity, the more problems a child will have, as you know from just spinal cord injuries in general. Like, the higher it is, the more of your body that will be affected. So some of these kids will be in a wheelchair. Some of these kids will have other, let's see. We're talking about on this page. 80% of them have normal intelligence, but as 20% won't. So they need early intervention for things like speech, physical therapy, and occupational therapy. Do you have a question? I mean, I think it's the same as any spinal cord injury. Well, I think it's one of those things will most likely, and then you kind of see how it develops. But yeah, I think that you can pinpoint it pretty well, and have a good guess at what kind of deficits the baby will have, depending on exactly where it's at. So one thing for nursing considerations that I think is so interesting about spina bifida is that I took care of one child with spina bifida when I was a nurse in Chicago many years ago now. And the child you had to have them, and you had to consider their latex allergy. And so actually one thing that you should think about when you think about spina bifida is latex allergy. Like, these kids are at such high risk for latex allergy. And they're not exactly sure why. They think it is thought to be due to all the exposure during procedures and hospitalizations, which latex isn't even used as much anymore, but these kids still have these high risk for allergy. So it's just something to think about, is that it's just something that's unique to spina bifida, is that they really, for whatever reason, have increased allergy incidence. With other nursing considerations is to encourage use of support groups, earlier intervention for these kids. Definitely will need PTOT and maybe speech and other things to help with if they have some sort of, if they don't have normal intelligence. And then reducing the risk, again, we've talked about this. What supplementation do we need before pregnancy? Folic acid. So we are going to move on to hydrocephalus. So a lot of times people will talk about we'll talk about water in the brain. And hydrocephalus technically is not water on the brain. It is deep in the brain. It's in the ventricles. You see here the ventricles that are these are normal ventricles, a more normal size at least. And these you can see they have increased CSF, and you can see how swollen they are and big. So hydrocephalus is the buildup of cerebral spinal fluid, CSF, in the ventricles. So the extra fluid increases the ventricle size quite a bit and puts pressure on the brain. So you can see, so it's down in there deep. So as it gets bigger, it's just pushing out, right? It's pushing the brain up, pushing it into the skull. It normally, just as a reminder, the CSF normally flows through the ventricles, bathes the brain, and then in the whole spinal column. It's a closed system. So pressure from too much CSF can damage the brain tissues, and then it also causes lots of different brain functioning impairments. It's typically caused by an imbalance of production or absorption of CSF, and this is can be from lots of reasons. We talked about malformations a little bit, and that Chiari-2 malformation, but just really any kind of birth defect, any kind of malformation as the brain is being formed can cause a little disruption in the fluid flow. Tumors definitely can cause any sort of brain tumor can cause a blockage. You know, brain tumors are so difficult because it's such a small space, and there's just not room for something like that in there. So even a small tumor could just cause so many problems, especially depending on where it's at. But we'll talk about brain tumors more when we talk about cancers. Infection and scarring. So infection, any sort of infection that you've had or the child's had can cause scarring. So that can cause some blocks in the CSF flow. Hemorrhage, any sort of traumatic birth injury, or myelomeningocele can all cause the CSF to not be able to flow as it should. So signs and symptoms in the infant are different than the older child. You should look for a bulging, intense fontanelle. Remember in infants, when you're assessing an infant, you always look at that fontanelle, no matter how well they are, no matter what. Like, always feel it, always look at it. That's always part of the assessment. Kids with hydrocephalus typically have a rapid increase in head circumference. They usually have when you look at them, they have an unusually large head. Although some kids just have unusually large heads. One of my brothers always had a big head. They did multiple CAT scans on him when he was little. He always had his own helmet for t-ball and football, and they ordered him his own special helmet and all that. But he was always perfectly fine. So it's just something to think about when kids have unusually large heads. They're irritable, have poor feeding. Their scalp veins, you can see the scalp veins in a lot of kids, especially really light, pale kids. But then they start becoming more prominent and distended looking. Sunset eyes, that's when your eyes are fixed downward, and so in the lower half of the iris is hidden by the lower eyelid. So they just kind of look like they're looking down. It's from the pressure from above. And all of these signs and symptoms, what is really causing all these? Right, increased intracranial pressure. So then in the older child, They don't have fontanelles anymore, right? So we don't look at that. But they have headaches. That's the main thing. They usually complain of headache. They can have blurred or double vision, change in their level of consciousness. They can be less alert, kind of sleepy, have some behavioral changes. Vomiting is a big thing. Vomiting is a big thing that you also wonder. Vomiting in the morning is a symptom of brain tumor. But the vomiting because of all the pressure. Double vision or strabismus, impaired balance and coordination, and also you can have delays or problems with previously acquired skills like walking and talking, which we talked about. We've talked about before, and hopefully you remember that anytime a child goes backwards in milestones, there's an issue, and it needs to be further investigated. So your VP shunts. So to get rid of some of this fluid, what they do is they put in a ventriculoperitoneal shunt. And this is not a cure. It's just a way to manage the symptoms. So what happens is they put a tube in the ventricle, and then they end up threading it in different places, but they thread it under the skin, and it ends up in your peritoneal cavity. And what it does is it shunts the fluid from the brain into the peritoneal cavity, and then you're able to absorb it that way. And what they do in kids is they put extra tubing in the, they do put extra tubing so that to allow for growth, so that it doesn't have to be adjusted for that particular reason. A lot of times they'll end up having problems with their shunt or having infection or other things and needing shunt revisions, but they do put extra tubing at the beginning to hopefully avoid some of that, or doing it just for that reason. So when kids get a shunt, a VP shunt, that's what we're talking about specifically in this class. Pre-op, you want to position them carefully so that you don't stretch or strain their neck muscles, because their neck muscles aren't very well developed at this point, and they're supporting this big, heavy head. Like any sort of edema or any sort of extra fluid is just kind of heavy, So the head's bigger and it's heavy. You always want to keep their head supported, and because also a lot of extra handling can also make their emesis worse if they're throwing up. And then also you need to do frequent assessments of their level of consciousness, their vital signs, and their neurostatus while they're awaiting surgery. Then after surgery, you want to keep them flat because you don't want it to drain too quickly when there's a lot there at first. So you keep them flat at first, and you monitor for infection and do regular neurochecks, whatever's ordered, but probably hourly. Typically check a daily head circumference to see how it's progressing. And then lots of family support and teaching. Families need to know the signs and symptoms of infection. They need to know if it malfunctions, what those signs and symptoms are. And these kids also, depending on how old they are, they should avoid contact sports. Anything that, although we should encourage other sports that aren't as likely to have some sort of head injury involved with it. One other thing is you do give antibiotics at some point during the perioperative time to hopefully avoid infection, because that is a big deal with these shunts, as you can imagine, which we're going to talk about on the next slide. Did you have a question? When they go first. All right, so the complications of the shunts. The biggest one is infection. The shunt is, I'm sorry? What's that here? It does break the skin, but it's a foreign body. So with these shunt infections, the greatest risk is within the first 3 months following surgery. Signs and symptoms of a shunt infection are fever, lethargy, erythema at the surgical site or elsewhere along the shunt device system, abdominal pain or apnea. They also can just malfunction. And usually what happens is you'll see signs of increased intracranial pressure because it stopped working. Infants, their symptoms are nonspecific, and we already talked about in slide 16. And the older kids, you can look back on slide 17. Those are for the signs and symptoms of the increased intracranial pressure. Other complications could be abdominal complications. These occur on occasion. You can have they can have perforation of the bowel. You can have an ileus, a pseudocyst, or any sort of abscess are potential problems in the abdomen from having that foreign body in the abdomen or in the peritoneal cavity. And then other problems could be overdrainage of the ventricles. And what happens sometimes when you have any sort of CSF leak, or if you have this child's had too much CSF come out in the shunt, then one of the big indicators is it really have horrible headache when they sit up, but then when they lay down, it's better. This has actually happened. My sister-in-law has problems with migraine headaches, and it was so bad one day that she went into the emergency department, and she had some sort of resident do her spinal tap, and didn't go well. And she ended up having a leak, got home, and her head was so bad she couldn't sit up. Took her back, and she'd had a CSF leak from that spinal tap. And so then she ended up being admitted and all that. But so it happens. And that's the main symptom, is when you sit up and it hurts, and your head hurts terribly. What do you think is the most common reason to remove a shunt of all? Infection. And one thing I remember from working with brain tumor patients is that when these shunts get infected, you have to take it out, right? But you need it still. So a lot of times what happens is you do, 24, 48 hours of antibiotics, and you put in an external shunt. So then it drains externally while you're getting your course of antibiotics. And then you end up taking that shunt out and putting, once all the cultures are cleared and you feel good about the infection being totally clear, you put the internalized shunt back in. But as you can imagine, there's a huge risk of infection with an externalized shunt. They end up staying in the hospital, at least where I worked, they end up staying in the hospital for that. It's very, it's difficult to deal with, and it's scary because, it's direct access to the brain. So we try to avoid infection as much as we can. A prognosis for hydrocephalus. It can usually be managed. It can often be managed by surgical removal of the obstruction, or can be, but usually the shunt is still needed. And the prognosis for increased intracranial pressure depends on the time of the length of time and the cause. Tumors, as you can imagine, have a high mortality rate. Untreated syphilis has a mortality rate of about 50 to 60%. And when it's treated, the survival rate's great. It's 90%. But about 50% will end up having a neurological disability, and about 50% normal to low intelligence. Any questions? All right, cerebral palsy is a disorder of movement, muscle tone, or posture. It is secondary to a brain injury or malformation that occurs while the baby's brain is developing. It can happen before, during, or typically soon after birth. There are occasions where it can happen from an infant, being dropped or in a car accident, but typically it happens before that. Etiology, usually they don't find the exact cause, but lots of things that can cause it are things like gene mutations, maternal infections that affect the fetus, fetal stroke, infant infections, traumatic head injuries in an infant, and asphyxia. It used to be that people thought that cerebral palsy was typically caused by complications during the birth process, but as it turns out, when it was studied, it ends up being only a small percentage, like 10% or so of cases. The clinical features, typically they're a little floppy, or they're rigid in the limbs and the trunk. There's involuntary movements, abnormal posture, unsteady gait, or a combination of all these things. Associated disabilities often seen with cerebral palsy. These kids often have visual issues or problems with their vision, hearing, speech and swallowing and chewing. They often have intellectual impairment and seizures. But one thing that's important about this also, like with spina bifida, is that this is brain damage. Like, it's not reversible. It's not curable. It's non-progressive. So the damage has been done. It doesn't get worse, but you can't fix it at this point. You can do a lot to help as far as PT and OT, and you can make their situation better, but you cannot fix it. So each type of cerebral palsy is caused by damage to a specific part of the brain. The most common part, the book goes over several different ones. The most common one, though, in 75% of the time, is spastic cerebral palsy, which is damage to the motor cortex and the pyramidal tracts. So just to remind you, the motor cortex regulates voluntary movements. So damage to that makes voluntary movement harder to control and less fluid. And then when you damage the pyramidal tracts in the brain, these are the roads of communication. So damage causes the inability of the brain to send the proper signals to the spinal cord. So in spastic cerebral palsy, so spastic is the inability of the muscle to relax. So in spastic cerebral palsy, they typically have jerky movements and muscle and joint stiffness. They can also have abnormal reflexes, stiff, tight muscles, which is hypertonia. Flexion, the muscles are really tense, and it really causes pain. You can imagine what it'd be like to have a muscle be flexed all the time. Sometimes they end up with contractures because of it. A scissor gait. Are you familiar with the scissor gait? A scissor gait is when I'm sure you've probably seen it before, when people have trouble walking and they scissor their legs. Like their legs kind of go over each other like this. Like kind of like, I don't know if I can do it, but kind of like when you walk, like it's kind of like this. And the leg goes over each other. Legs go over each other. They can also walk on their toes and keep their hips flexed. They definitely have difficulty controlling their voluntary muscles. So one of the things that they can do to treat this, if it's localized, you can use to localize to a specific muscle or just a few muscles. Sometimes Botox can help to release that muscle. If it's more generalized, sometimes they use a baclofen pump to try to, a baclofen pump they use.
Yeah, we have
And Botox has to be redone, though, every 3 months. Is that right? Oh. Did you have a? I don't know, to be honest. Does it come in a cassette, or does it? Have it done? I don't know. We can look it up. Good. That makes it nice and easy. That's what, if you've seen how you access a port, a Venus port. Does anyone know how you do that? A Venus port? Are you familiar with a Venus port? Yeah, so the Venus port is, it looks like, it's basically a big piece of metal, and it has a rubber piece in the middle, and it's under your skin. And it's used for things like chemotherapy and other medications that are hard on your veins. And basically, yes, it's under the skin, somewhere in the chest area. And it's so nice because, like, the baclofen pump, like, you don't have to do anything with it. Like, you don't have to keep it clean. You don't have to worry about it when you're at home. But you access it with a needle in the same way. Like, you, and then the IV tubing hangs off of it when you're using it when you're inpatient. So I think it's probably the same idea. Like, you just feel it. You feel where it's at, and you put the needle in. And for this, it sounds like, I mean, a person who's trained to do it, you stick the needle in and access it that way. But it's nice, right, that you don't have to do anything with it at home otherwise. So it really takes down the risk of infection at home. All right. So the medical care team for children with cerebral palsy is multidisciplinary. You really need an interprofessional approach to care for these complex neurodisorders, like your spina bifida, like your cerebral palsy. So you need people like your pediatrician, your neurologist, orthopedics, nursing, PT/OT speech, social work, and special ed. You really want to promote optimal locomotion. Communication and self-help. You want to have the whole team's input in planning and coordinating. You always want to partner with the parents, as we've talked about over and over. Hopefully you have that in your head from this class. We want to make it family-centered, since the family is the constant in the child's life. So the goal overall is optimal development and achievement of the child's highest level of function. And what is the role of PT, OT, and speech? Does anyone know the differences between PT and OT and speech? Yeah, so PT helps increase strength, flexibility, and mobility. They also provide like walking devices and different things to help them be mobile. In OT, basically you work to help with developing daily skills, and you use adaptive support supplies and devices to help with that. And then your speech therapy addresses speech swallowing and language difficulties. Why don't we finish up with CP, 2 more slides, and then we'll have to take a break then. So nursing considerations are to contribute to and support the plan of and be part of the interdisciplinary team. assess need for increased calories and prevent aspiration. You should monitor their growth chart, give easy-to-chew foods, modify their utensils if needed, and monitor their growth. Maintain skin integrity, and promote physical mobility. One big thing is fall precautions. You can imagine with some of these children who don't walk well or scissor walk or whatever, like especially when they're in the hospital, you need to you need to pay attention and keep them from falling. And you also should maintain proper alignment in bed or in the chair, using pillows, towels, bolsters, or whatever you have. And then also doing range of motion exercises. They need PTOT to prevent some of the contractures. You can see this picture is actually of a mom or a nurse or someone, but you can see how they're supporting the jaw when they eat. So other things to consider is careful assessment of low birth weight, preterm, and low APGAR infants. Some of the earliest clues of CP, though, aren't usually quite that early, but one of the big things is persistence of your primitive reflexes beyond 6 months and delayed development. So when your Maro reflex, remember your startle, when that goes beyond 6 months, you wonder if there's something else going on. Also the fencing reflex, which I don't think we talked about too much in this class, but that's tonic neck. So basically what happens is when the baby turns your head to the right, for instance, then the right arm extends and the left arm flexes. The legs may or may not follow. But when that goes beyond 6 months, then you worry about that also. You also want to identify the kids with motor problems, the abnormal muscle tone, or abnormal posture. So when they have head lag beyond 6 months old, remember head lag is when you pull on them and they're either hold their head up or the lag is when they keep doing this. They're unable to pull it up on their own. You pull them up. They keep their back arch. They have poor trunk control and balance. Toe walk or scissoring are all things to wonder about some sort of motor problem. Also, asymmetric or abnormal crawling. So if you use just 2 or 3 of your extremities instead of all 4, like a normal crawl, is something to think about. And then hand blank prior to 18 months old. Head dominance. So this is a big thing, I think, a big thing. So kids should not have a preference they should not be right or left-handed at this stage. If they are, they probably have some sort of, there's some sort of brain damage or some sort of motor deficit. One of my good friends, actually, from high school, they live in Indianapolis, so I was not anywhere near them, but her child, she told me after the fact that she didn't know that was an issue, and her child was right-handed from so early on, and it turns out that he has a significant deficit on one side of his body, and it was from, but that was the first thing that was noticed, was the hand dominance. Nothing else had been noticed at that point, but hand dominance should not happen. One way you can, at this young ages, one thing that you can do to check that is if you lay on an infant's face, if you put some sort of washcloth or something on their face, they should grab it with both hands. Or it's really concerning if they don't grab it at all. But they should not take it off with one hand, as we would, right? So that's just something to think about, is that they should not have hand dominance or preference prior to 18 months old. When they're little? When they're 10? I don't know that do they always suck the same thumb? No. But what about with other things? So, I don't know. I mean, I've never heard of, I've never heard of sucking thumb preference matter. But I do know that if you only use one hand or one side of the body, that's an issue. All right. So these kids are often diagnosed between 6 months to 2 years old. And the developmental assessment of blank should be done at every visit, every time, so that early intervention starts ASAP. Milestones, developmental milestones. All right, we go ahead and take a break now. And then, let's see. 33 people. All right. We're going to divide up into groups when you get back. We're taking a break right now. And then after that, we're going to get in groups. Milestones. Which one?
The last one.
Development assessment of legs. Should we not every visit? No, it's milestones. Developmental milestones. So aseptic meningitis is also known as what kind of meningitis?
Bacteria?
Viral. Viral meningitis. It's most commonly caused by enterovirus. The onset can be abrupt or gradual, which is a little different than bacterial meningitis. It's a self-limiting disease. It's important to differentiate between viral and bacterial because bacterial is not self-limiting. Viral. Presenting signs and symptoms can be the same as bacterial meningitis. Headache, fever, photophobia, neutral rigidity, which is when you don't really want to flex your head because it hurts in your neck. We diagnose based on clinical features and cerebrospinal fluid findings. The treatment is, once you know that it's viral, it's just symptomatic. Tylenol for fever and muscle aches, pain, maintain your hydration, and then also just position for comfort. But until you know that, a lot of times you'll end up treating with isolation and antibiotics until you know for sure that it's viral, and then you stop those things. Okay, so bacterial meningitis. I have a little case study. I want you guys to divide up into groups. I think it'll end up being 4 groups of 7, and then let's see, and then a couple of you. I think there'll be about 2 extra, and you can go into whatever group. I think, if my math is right. But anyway, what I want you to do is you have the case study on your sheet, and then here are the case study questions. And once you divide in your groups, we can pick a group 1, 2, 3, and 4. Okay. And then also, so what I want you to do in your groups is to go over your questions, and then someone from your group is going to talk about it to the rest of the class. And then, you mean group 2? You guys want to be group? You guys be group 3 over here, okay? 3. Group 3. So let's see, how many do we have? 1. So febrile seizures are convulsions or a seizure that occurs during the course of a fever. It affects about 3% of kids, typically between the ages of 6 months and 3 years. It's really rare before 6 months or after 3 years old. It's just considered a transient disorder of childhood. The cause is unknown, but there is a familial component. Usually there are multiple members in the family that have the same thing. And it's usually with a temperature that's greater than 101.8, and it occurs typically during the temperature rise, not after a prolonged elevation. Usually, if the family chooses to seek medical care, it stops before reaching the facility. But if it continues, you can use Ativan rectally and Tylenol rectally to decrease the fever. So it used to be that they recommended diazepam, Valium, but Now, the newer recommendation is Ativan because there's less respiratory depression and hypotension. How does what, sorry? Tylenol. Is it and Tylenol? Rectally, or two separate things? It doesn't. You're right about that, for sure. So I'm sorry, I guess maybe it wasn't clear on there. The Ativan is used to stop the seizure if needed, and the Tylenol is used to decrease the fever. So typically what needs to happen really is just support. You need to support the parents. It's a scary thing, I'm sure, to see your child seize. You just provide emotional support. Typically, it causes no long-term issues at all. There is a small group of kids, though, that if they have prolonged seizures that last more than 30 minutes, there is a risk of epilepsy with them. That's about 30 to 40%, although it usually doesn't come for many years after. But typically, febrile seizures are benign. They're just scary. Usually as the temperature is spiking up. All right.